In terms of NMOSD awareness, where do we currently excel at, and where do we currently need more improvement?
I think our awareness of NMOSD has certainly been improving over time. I think most providers are not going to miss that patient with severe optic neuritis, the patient with severe transverse myelitis. NMOSD is going to be really rising to the top of the differential. And then as a neuro-ophthalmologist, we're predominantly educating ophthalmologists and of course some neurologists as well. And I think even general ophthalmologists are recognize the importance of looking for the NMO aquaporin 4 antibodies in any patient with optic neuritis, especially if it's severe. It's some of those kind of more less common symptoms that we need to educate our providers about, like the nausea, the vomiting, the hiccups that you get from Erie-Postrema syndrome, which is, again, the third most common way that NMOSD can present. So that's still some educating we need to do. And then there's MOG antibody-associated disease it's a completely separate disease, but it has a little bit of overlap with NMOSD in terms of how it can present. And I think some providers are still getting a little bit of confusion between that MOGAD and NMOSD diagnosis. Fortunately, just this past month, we've got the International Consensus Diagnostic Criteria for MOGAD that just got published. And I know that we're recently, actually, a bunch of experts are going to be coming up with a new international diagnostic criteria for NMOSD, last published in 2015. But we need to kind of update that now that we know that MOGAD is a separate disease. Again, in 2015, we didn't even know MOGAD existed.
How have we improved in our use and understanding of these therapeutics? Obviously, as drugs get approved, there are some nuances to who may be best candidates, but how have we sort of improved on that aspect?
Yeah, it's really nice that we now have FDA-approved medications for NMO. Really, for the longest time, we had rituximab. We knew it was successful, but it was all off-label usage. And again, in 2019, we had 3 randomized clinical trials, all showing effective treatments. We've got enebilizumab, satralizumab, eculizumab. And again, these were all shown to be very effective in reducing relapse compared to the placebo. So it's nice that we've got evidence-based medicine to show that these medications work. In terms of our choice, it really depends on the patient. Some patients, they'd rather have a treatment every 6 months, so they'd probably go with enebilizumab, that CD19 inhibitor. Some patients would rather be able to administer the medication at home subcutaneous rather than IV, so they might pick satralizumab, an IL-6 inhibitor. There's some patients that fail rituximab, which again was our kind of go-to medication. Then we might use eculizumab, the complement inhibitor. The PREVENT study showed there was a 94% reduction in attacks with eculizumab, but the drawback is it requires treatment IV every 2 weeks. And so, our treatments really kind of depend on the patient, their preference, their disease. But the good part is, again, we've got these FDA-approved medications, all proven to be effective in very well-designed randomized clinical trials.